We now move to breast cancer. 65-year-old patient is found to have a solid 2-centimeter mass in the upper outer corner of the left breast. What is the most common site for breast cancer? It is the upper outer quadrant. A biopsy is consistent with infiltrating ductal breast cancer. The most common breast cancer is infiltrating ductal breast cancer. 80% of all breast cancers. Most are unilateral. They start as ductal carcinoma in situ. I'll show you what that looks like, which then breaks through the basement membrane and it becomes invasive. With increasing size and fibrotic response, it becomes stony, hard mass. Here we have a normal duct, and you can see the lumen within it. As we start to get hyperplasia, you can see the nuclei look normal, they're benign. This is benign intraductal hyperplasia. Here we now start to see changes in the nucleoli and the nucleuses, and you can see this is atypical. I don't like this. This is heading in the wrong direction. Now we have the duct completely filled with carcinoma in situ with these atypical cells. What's the next thing that's going to happen? It's going to break through the basement membrane and become invasive. And here we have invasive ductal carcinoma. So, ductal carcinoma in situ is a precursor for invasive cancer. Infiltrating lobular carcinoma is the second most common breast malignancy. 10% of all breast cancers, often unilateral. It starts as lobular carcinoma in situ, which then invades the basement membrane. This is better prognosis than ductal carcinoma. But I want you to notice that there is a precursor stage, which hopefully can be picked up early. And that's the idea of the mammographic screening. Inflammatory carcinoma is uncommon, rapid growth, early metastasis. It blocks the skin lymphatics, which leads to then an inflammatory response. It looks red, swollen, and warm. This is where you get the peau d'orange, the appearance of orange, peel, edematous skin, and here's what it looks like. You can see it is red, it is inflamed. And look at the peau d'orange on the skin. This is edema, and the hair follicles are what retracts the skin and gives it the orange-like, orange peel appearance. Paget's disease is an uncommon breast malignancy. Prognosis is better than with the invasive ductal or lobular. It can appear like psoriasis or eczema. Pruritic red scaly rash involves the nipple. It can then spread out more. I'll show you what that looks like. The nipple can become inverted, and it can mimic skin conditions. Here is Paget's disease of the nipple. And then you can see how it looks like eczema. What do you think of this? This doesn't look quite as good. Breast cancer is the most common invasive cancer in women. 1 in 12 lifetime risk, which is high. The risk increases with age. 2/3 occur in women over 50. It should be considered a systemic disease at diagnosis, even if the lymph nodes are negative, even if it's small. This patient is the candidate for chemotherapy and probably radiation. Relative risk is 100 times that of men. Men can get breast cancer as well, but far more commonly in women. The risk of breast cancer in a female is equal to the risk of lung cancer in a heavy smoker, and it seems to me like that is discrimination against women, but that's it. This shows the most common cancer in women, which is breast. The most common cancer death in women, however, is lung. In 1987, lung cancer exceeded breast cancer as the most common female cause of cancer death. Here you can see deaths, and here you can see cases. Thank you, Virginia Slims. #1 cancer death in women. Very clever. Women may be more susceptible to tobacco carcinogens, and the same amount of exposure may give a higher risk. And I think women need to know that. Risk factors for breast cancer. This is looking at incidence of breast cancer with age. We're looking at all races, which is the yellow, white women, which is the purple, and the orange is African American. And you can see that white women have higher rates than do African Americans, but notice it is with increasing age. Age is clearly a risk factor. This is looking at breast cancer risk age 30 to 39, 40 to 49, 50 to 59, and you can see with advancing age, significantly increasing risk. Now, when you look at risk factors generally, other than age, BRCA gene, 15 times the relative risk. Ductal or lobular carcinoma, 15 times relative risk. That would be a good board question. Atypical hyperplasia, I showed you a picture of that, is a risk factor. Breast irradiation, less than age 20, let's say, for instance, for Hodgkin's disease, and you're irradiating the chest. That would be increased risk. Family history is an increased risk as well. When we look at breast cancer rates in the United States and Japan, there's a significant difference. What do you think it's from? My suspicion is dietary, and I think there's reasonable evidence to support that. The most common breast cancer is infiltrating ductal. Lobular is much less likely. The most malignant type is inflammatory, and the dermatitis, Paget's disease. The most common site is upper outer quadrant. Metastasis. Initially in the surrounding tissue, increase in tumor size. Then it gets into the lymphatics and the axillary internal mammary nodes. And then it goes systemically through the blood vessels. And you have distant metastasis. So the staging of breast cancer is based upon T, tumor, N, nodes, M, metastasis. T, N, M. Some have thought that perhaps you can avoid doing an axillary node dissection, which has the morbidity of lymphedema, by doing a sentinel node biopsy. What you do is to inject the area around the tumor with dye, and then go to the node, which would be the first one that drains, and see, is there any cancer in that? If it is negative, then perhaps you don't need to do an axillary node dissection. And this is a sentinel node biopsy. You can see the dye in the node. Prognostic factors. The size of the tumor is going to be important. Less than 2 centimeters, over 2 centimeters. Whether nodes are positive. Whether estrogen and progesterone receptors are positive or negative. And you'd like to have positive. DNA content. Is it euploidy or is it aneuploidy? So the size, the nodes, the receptors, and the DNA content. The best prognosis is a small tumor, negative nodes, estrogen, progesterone receptors present, because then you can use hormone blockers like tamoxifen, and normal DNA content. This is a histology of a lymph node, and here you can see breast cancer cells which have entered into it. A healthy 55-year-old woman had a lumpectomy, negative margins. She had an axillary node dissection. The tumor was 2.5 centimeters in size. So there you've got already a stage 2. Stage 1 is less than 2 centimeters. More than 2 is stage 2. But she had 3 positive nodes on her axillary node dissection. So that puts her in stage 3. The tumor was positive for both estrogen and progesterone receptors. She comes for an opinion about further therapy. If it is early stage, if it is small, if it is unilateral, a lumpectomy may be adequate. When would you do a mastectomy? A simple mastectomy may be recommended with ductal carcinoma in situ or lobular carcinoma in situ, because we have 15 times the risk of breast cancer, and you don't know where it could develop in the breast. A modified radical, where you do not do an axillary node dissection with the larger tumors, but the radical is where you do a breast removal plus you remove the muscles of the chest wall, a radical mastectomy. Radiation treatment always after lumpectomy, because you have to consider breast cancer a systemic disease. Hormone therapy, if estrogen or progesterone receptor positive, and you can use oophorectomy, which will decrease premenopausal women's estrogen. Tamoxifen, we talked about that. And aromatase enzyme inhibitors now will prevent the conversion into hormones. Chemotherapy, if positive nodes or the size is over 1 centimeter. So for most patients who get a lumpectomy, they will get radiation therapy and chemotherapy. And then depending on the receptors, they may get hormone treatment. So this is talking about the aromatase enzyme inhibitors for breast cancer, suggesting that there may be an improvement in outcome with that. So here we have the lumpectomy. This is a skin-sparing mastectomy, where you do a subcutaneous mastectomy. This would be done with a ductal carcinoma in situ or lobular carcinoma in situ. A total simple mastectomy, where you do not take out the nodes. Modified radical, and the radical where you take out the chest wall muscles. This is a patient who had a simple mastectomy, who has not had a breast reconstruction. This is radical mastectomy, and you can see she's got the lymphedema of the arm for which she's wearing this device. Breast reconstruction can make the patient look very normal after, and this is recommended. Lymphedema and the stocking, which can help. Radiation, to this degree, is not done anymore. This was excessive. This looks at the 5-year survival of breast cancer, looking at negative axillary nodes, 1 to 3 positive nodes, 4 or more positive nodes. And what I want you to notice, that even with negative nodes, the 5-year survival is only 80%. And the reason is because the nodes may be having micrometastases that you don't even see, and yet they are present. That's why it should be considered a systemic disease on diagnosis and get adjuvant therapy, radiation chemotherapy. This looks at the deaths among women from lung cancer, which is in green, breast cancer, which is in the red, and cardiovascular disease is by far the most common. Okay, the last slide shows what has happened over the last 80 years to the rates of various cancers in women. And it shows where we have been successful and where we have a long ways yet to go. Breast cancer, we really haven't changed the outcome very much in terms of breast cancer. We've done a pretty good job with colorectal cancer with the occult stool blood analysis. You can see with cervical cancer, we've done a great job with pap smears. Ovarian cancer, because there's no early detection, no early symptoms, not so good. But what we really need to address is the issue of lung cancer in women, and this is growing and can be almost totally preventable. And that is the end of breast cancer.